folks, and welcome to part 2 of a special edition of the Dr. Meade Show. We're here at the Mohegun Casino in Wilkes-Barre, Pennsylvania. It's important to me for 2 reasons. Not only did I grow up here a few miles from this facility, but I'm able to introduce you to my high-performance team. This team allows us to do 4 times the average amount of knee surgery of most orthopedic surgeons in the country. The volume isn't important. What's important is our efficiency, our outcomes, our patient satisfaction, and a very, very low number of complications. I couldn't do it without this team. Again, it's like Tom Brady or Peyton Manning lining up and saying, who's going to block for me today? He would have terrible statistics. You would not be able to tell how well he performs. It's the same thing in surgery. In most hospitals that we go into, we never know what team is going to help us. I went to the draft and I picked the best team that I could find. This was the healthcare draft. Starting on the left side, Tom Witter has been in practice as long as I have, since the 80s. R.J. Ritchie, all-star, knee performer, great PA, can't do without him. On his right, Michael Joyce. He's one of the best surgical first assistants I've come across. He's a great thinker, a tinkerer, great with his hands, helps us produce new instruments in the OR. The glue that holds us together right in the middle, Molly Wookich. We operate 60% of the time, so 3 days out of the week we're in the OR. Somebody has to coordinate all the preoperative and postoperative questions, concerns, any complication. That's Molly. Any system has to grow. Our system with coordinated health is growing exponentially. Carol Matrazzo, she's a magician. She is responsible for the growth of coordinated health north of the Lehigh Tunnel. She started the Lehighton office, the Hazleton office, and soon the Wyoming Valley office, I'm proud to say. Pam Quarry addressed the problem. Non-steroidal anti-inflammatories, Bextra, Vioxx, high incidence of stroke and heart attacks. We stopped giving that 5 years ago. We went into the natural mode. We suggest omega-3 fatty acids for anti-inflammatories. I haven't prescribed one since Pam was on board. She helps patients with a more natural approach and get off any medicines that they don't need. Marie Olwine, one of the best OR nurses I've come across. She's on our travel team. We could take our team on the road and reproduce our surgery tomorrow without missing a beat. Marie's on the reconnaissance team. She would go out ahead of time, educate the OR, decide if they're good enough. If not, she will scrub in. She'll help them until we can convert that team to our caliber. So with that team, I am so proud that we are not only one of the best knee surgical teams in the country. I just came back from a tour of England and Ireland where we're talking about some new knee developments. And frankly, our orthopedic surgery in this country is literally the best in the world. So this team is literally one of the best teams in the whole world. We have the privilege of just doing knee surgery. We don't do ankles and hips. And thanks to them, we can give folks some of the highest outcome results in the country. And I see in the back, I'm really surprised to see Steve Sofka. Steve, come on up for a second. He's an example, and I didn't ask Steve to come here. Steve just looks familiar. I thought he was in a hospital gown this morning, but but Steve, you're looking pretty good for just getting out of the hospital. But actually, I think it's been Tom, a week or two. Hand them the microphone. Pardon? 10 days. Oh, 10 days. So Steve, you're looking pretty good. You're looking pretty good. How's that knee feeling?
Good.
Is it?
Feeling real good.
Really? How was your experience with my high performance team?
They are good.
Did they push you too hard?
The therapist is doing that.
Did they? Yeah. Yeah. We call them physical terrorists when they do that. So, but anyway, I just wanted to see you walk up here. And again, we can't, we can't guarantee the same result in every patient. Everybody has different, conditions. We do young and old. We do big and small. We have people with diabetes, neuropathy. But it's not unusual for our patients to walk home with one knee, be driving within a few days. I'm embarrassed to tell you that I did my dad's knee replacement, and I told him he can't drive home, and he said, okay, Tom, I won't drive home, and he drove out of the parking lot and made my mother get out of the car. And he said, Joan, you can't drive on the turnpike. And so that's the old retired state policeman in him. So he drove home after 4 days. But that's not unusual. So it slows you down, but it doesn't incapacitate people. I say for a month, it'll slow you down. But, and Steve's a great example of that. Steve, thanks for coming up. So I'm going to get back to some questions. Thanks, team. We're going to start the second show with a question on the female knee. Again, if you're not an educated consumer and you watch TV, you say, geez, I'm a female, I want the female knee. Well, really, the company that came out with the female knee did not have a lot of sizes that fit females. So they realized this, and a lot of the other companies had a variety of sizes, including extra small sizes for children, juvenile rheumatoids. The Asian population have little knees. Well, this company did not. So they realized that instead of just coming up with a bunch of sizes, they decided they'll come out with the female knee. They marketed it, and for years people come in and say, I want the female knee. But after it's been out a while and we get to look at the data, you know, an interesting thing happened in our literature is that the female knees did not do as well as the other knee companies that had a larger selection. So there was no advantage of the female knee. It was basically just sizing the knee correctly with the prosthesis that fits your natural anatomy. So in reality, many of the other companies had female knees out there, and the way to address that problem is, do you have the size that fits me? If you have small, medium, and large, that may not be enough. You may need, you know, extra small, small, medium plus, medium minus, large, extra large, 3X, just like clothes. And so this company had basically 3 sizes, and now they're up to snuff. So that's sort of the answer on the female knee. Yes, question?
Yes, doctor, I was just wondering, since you have such a sophisticated and fine-tuned operation, after sending your results in and your costs in to the insurance companies and the federal government, have you ever been reviewed by these people to find out what your expertise and secrets are?
Well, we're you know, again, try to deal with the government and the insurance companies. It defies common sense. It's the death of common sense. I'll give you an example. If somebody's in the hospital with an infection and you're on Medicare, some of these infections could require 6 weeks of IV antibiotics. And the most inexpensive way to treat that is to put a PICC line in, send the patient home, and get IV antibiotics at home. Literally costs pennies a day for whatever the antibiotic costs. Medicare will not do that. Our system is broke financially, but you know what they'll pay for? Thousands and thousands of dollars a day to stay in the hospital for 6 weeks to get those antibiotics. So your question is well meant. Coordinated Health Hospital has the data. You could look this up online. We are 20% lower in cost for a total knee replacement than many of the big institutions down in the valley. The insurance companies don't really care about that because their customers are these large integrated delivery systems. You would think that the federal government, the insurance carriers would figure this out. So it doesn't. All we can do is produce the highest quality at the lower cost, and I think with time we're going to have to figure this out because we can't go on forever. Our system is broke. One more question.
Has fish oil bleeding risk? What does that?
That's a great question. It's another problem I address all the time. Does fish oil put you at risk for bleeding in surgery? Let's answer it right after this break. The question was, does fish oil increase your risk of bleeding? The quick answer is no. But whenever you go into surgery, this is a dogma that you can't change. Everybody will tell you to stop your fish oil. It increases your risk of bleeding. So before answering this question, I had to drill down on all the literature out there. There is no literature to substantiate any increased risk of bleeding with fish oil. Even the FDA says that as long as you're taking less than 3,000 milligrams of EPA and DHA, which is really 10 pills a day, there's no increased risk of bleeding. But listen to the logic in medicine. What's our biggest concern? We're not so worried about bleeding. You know what we're worried about? We're worried about clotting. We're worried about clotting in your legs, clotting in your lungs, fatal pulmonary embolism, heart attack, clotting in your heart. And fish oil, look what our system does. This is dogma that hasn't been addressed. It decreases your risk of blood clots, it decreases your risk of arrhythmias, it decreases your risk of a stroke and a heart attack. Those are the big, it's devastating. If we do an operation, someone has a heart attack or a stroke, it's devastating. And what do? We tell people to stop one of the few drugs, nutraceuticals, not a drug, that helps them. So, you know, in the old days, food is medicine. So this is one of those things. Do they tell you to stop eating salmon? No. So anyway, that's the answer. Yes?
Doctor, what if you're allergic to aspirin?
So, you know, again, if you're allergic to aspirin, if you look at the guidelines by the American Academy of Orthopedic Surgeons, there's a couple options. Remember, historically, we put everybody on some other blood thinners. There are some other options. The danger level goes up, but Coumadin is one of those options that you could go on for 3 weeks. We now have subcutaneous heparin where you could inject that. But frankly, even our guidelines say if you have a bleeding issue and you can't do any of these, you know what you can do? Early motion, compression boots, and get out of bed. So we can address it any way that has to be addressed. But basically, it's 1 aspirin twice a day for 6 weeks if you could tolerate it with food. But we have, we have a bunch of other options. You know, when I first started medicine, total knees were in the hospital for a week. They were on these machines that went back and forth, these CPM machines. And frankly, if you look at the data, these CPM machines really didn't help anything. You didn't get better faster. And frankly, with the healthcare issues going on, I've had a number of people that had staff at night that were less than well trained, people of different sizes, their legs are numb, and you know what? They put them on these machines, it leans on their nerve, they wake up with a foot drop. We do a great knee operation, they have a foot drop for a year. It's devastating. So we get rid of all the outlying complications or variables that can give us a bad result. But an aspirin allergy is pretty easy to deal with. And I tell people the fish oil, the early motion, and the boots.
Yes, doctor, you were talking before about just recapping the knees. What would constitute a complete knee replacement, and would you recommend having both knees done at the same time or a time period in between the two of them?
Yeah, great question. Again, if you have your hip replaced, you know what? You take out the ball and socket, you get a true hip replacement. Most modern knee surgeons now are doing these complete knee resurfacings. We still have much larger procedures where we take out a big part of the knee. Let's say a revision procedure. Somebody gets an infection. You know, it's like taking the door jamb out. If you take a door jamb out, you're going to lose some drywall. You have to lose some tissue. So if we take a knee out, we're going to lose some bone. We're going to have to put a prosthesis with a big rebar rod up the femur and down the tibia. Or if you have a tumor that affects your whole knee, literally, we could take out half of your femur, half of your tibia, and do a complete replacement. But 99% of all the knees in 2012 should be partial or whole knee resurfacings. The bilateral question, people come in and say, can I have both knees done at once? And again, here's the schizophrenia of our system. If it was up to the financial incentive of the physicians, which some of them are, they won't do bilaterals because insurance companies and Medicare only pays you half for doing the second knee. So a lot of docs will come up with reasons not to do it that have nothing to do with your best interest, but have something to do with their financial best interest. You know, how about if you went in and asked for, you know, you were going to put 2 doors in somebody's house, and the rule was, well, if I put 2 in, we're only going to pay you half for the second door. But that's the schizophrenia in medicine. But to answer the scientific question, I think doing 2 at the same time, there is a big indication for that if your health is good enough, you're relatively chronologically young. Now, I've done bilaterals in people as old as 88, and it saves time out of your life. So if you're in good health and you're strong enough, and both knees are equally as bad, on any day you can't pick a good or a bad knee, then you can do both at once, and the cumulative risk is only the same as doing both knees independently at the same time. So it's still very low, and it's not twice as hard, it's not twice as painful, and you recover in the same amount of time. It's a little harder the first 2 weeks, but usually it's an automatic ticket into rehab, whereas if you do one, the rehab facilities are pretty stingy these days. They won't let you in with one, but if you have two, it's a reason to do it. My biggest risk with two is heavier people. In America, obesity is a big problem, and we'll do 1,000 total knees a year. 12 times a year, someone will fall with bilateral knees, split open their knee, split open their quad, and we're back in the operating room because you're weak and they don't realize it. So really, we do put a limit, not a specific number, but I look at people, their size and their strength, and if they can't handle it, we'll do one at a time.
Is there like a process or procedure that you recommend before entering into that, such as some physical therapy in advance?
Yeah, again, it's another great question. You know what the reality is? Most people say, I want to get in shape and lose some weight. In reality, if you need 2 knee replacements, you're not going to do it. It hurts too much. And they get out there and they try, they get on the treadmill, they walk, they get on a stationary bike, they actually develop more pain and swelling. So anything they can do within common sense parameters, get in a pool or a stationary bike, are probably the 2 best things. But often these folks have bad arthritis, it's a catch-22, they're above their ideal weight, and it's not going to be a miracle to get in better shape or lose weight until their knees are fixed. Question in the back.
Is it truly feasible that you can expect to run again after being told, no, you can't because of the knee replacement? And if you do incorporate that back into your lifestyle, is it true you wear out the hardware faster than a sedentary person?
Yeah, so again, it's a great question. It's analogous to buying a Corvette and driving out of the shop, and on the way out you say, I have one more question. Can I drive this Corvette off-road? And the guy goes, you can, but it's not really designed for that. And it's the same thing with knees. I could tell you, I've got patients out there running triathlons, policemen in Harrisburg running triathlons. I had a guy come up from Delaware. We did a knee replacement so that he could run his 39th and 40th Boston Marathon. And I mean, so, you know, our job is to sell you the Corvette. Your job is to drive it as you want. But we also give you an instruction manual on how that Corvette may last longer. So you can run to get, you know, to get out of the way of a car. But it gives you the ability to run, but it doesn't necessarily wear out quicker like a tire, but your risk of loosening the interface between the metal can wear out. So, but we've got people playing a doubles tennis, you know, nothing crazy. They're not running 10 miles a day, but you can jog a little bit, you could run to get out of the way of a tractor trailer. But it's not high, you know, it's not high on my list of things to recommend, but it's a great question. Yes?
When you do the knee replacement, are you actually going to go in and do this, or does a computer help you do this?
It's a great question. Let's talk about robotic surgery and computer nav surgery, and let's answer that question after this break. Okay, the question was, does a robot do the procedure or do we do the procedure? It's interesting. I was on the development team for one of the major implant companies to look at this. And it was really cool technology. And I like really cool technology, but it has to answer 2 questions. Does it make me faster or does it give the patient a better result? And right now the answer is no. It takes much longer to do it. And it's like a big router that you have to program. It costs a lot of money. It adds another machine to the OR, another technician, and a very, very small percentage of surgeons are doing that. Why is that? Surgeons are smart people. If you come up with a new tool and it works, we use it. You know, if you're a carpenter in the old days and they developed a circular saw, it doesn't take a genius to figure out the circular saw works. But if you come out with a 6-in-1 saw, you figure, you know what, this thing is too complicated. I'll just use one saw at a time. It's the same thing with robotic surgery. So it really hasn't caught on. Neither has computer navigation. It's used as an advertising tool, $250,000 machine in the OR. You have to drill other holes into the knee. You have to validate it. By the time a surgeon validates that procedure, we are done with the operation. So less than 3% of all surgeons have embraced this technology. So it's cool, it's out there. It doesn't make a lot of sense for the majority of surgeons. What makes sense is one of the other projects we were involved with called Otis Med early on, where we took the computer out of the lab. We developed a 3D shape-matched guide 2 weeks ahead of time. It showed up in the OR. We put it on the knee, and then we could make the appropriate cuts. Of course, the government got involved and took that off the market, and when it came out again, it was a different product. So the 3D shape-matched guides are one of those things, you know, that are out there as a great advance. But the computer and the robotic surgery is really not a great option. And the last caveat is I had a patient come to me who had a partial kneecap replacement done by a surgeon that had no clue how to do it. He was a sports doc, and he just ordered the computer and the software didn't work. And so he didn't know how to default. That's analogous to an airline pilot saying, I can fly on autopilot, but once it goes off, I can't land the plane. And he couldn't land the plane. I ended up having to revise 34-year-old female, partial kneecap replacement. I was putting crooked to a whole knee. So robotic surgery is not the panacea. Yes?
I know you mentioned that you do spinal anesthesia, but what about a person who might have spinal stenosis? Would it affect that, or
Yes.
is there a way to do maybe a femoral block or something?
Yeah, again, great question. Biggest risk of surgery is general anesthesia, putting someone to sleep. And you know what? Using general anesthesia does not block the pain fibers. It's probably the worst option for knee surgery. So you're sort of asleep, but if you watch somebody under general anesthesia in the operating room, as soon as we make an incision, you know what happens? Their pulse goes up, their blood pressure goes up, their brain knows that they are being violated. They know they're being attacked. And so you know what happens? As soon as they wake them up in the recovery room, they're in enormous pain. The anesthesiologist had to give them morphine. They're sick to their stomach. They have a sore throat. So you don't have to do that too long to figure general anesthesia is not the way to go. It is not unusual for me to see people have an outpatient arthroscopy that were put to sleep. It's absolutely crazy. So regional block is the way to go. Usually spinal. If you've had spinal stenosis or back surgery, we can do distal blocks. We could just numb up your leg with the femoral nerve or the sciatic nerve and IV sedation. So there's almost nobody that we can't do with some regional block. And it also decreases your risk of a blood clots, DVT, and pulmonary embolisms. That's how we do all our surgery. Plus, it allows you to go home. One last pet peeve I think I'm going to throw up there. I saw a patient the other day come, and they brought in an X-ray. Remember the X-rays you hold up like this? And I go, what's that? And they go, well, you know, I have a second opinion. I didn't have such a great result. You know, would you look at my knee? And I said, wow, we don't even have X-ray boxes anymore because technology, you know, has passed that by. And so I had to get a digital X-ray, which is really what we do. And she said, well, I had to pay $30 for this. I said, you're kidding. I said, you paid for it once. You know, this was your. He goes, no, my doctor wanted that. And I look at this in this day and age and say, it's like walking into a computer store and asking to use the phone, and they give you a rotary phone. What would you say? You'd say you're not keeping up with technology. And that's what I see. If some of these practices are not keeping up with the X-ray technology, my question is, what are you keeping up with in the world of orthopedics, trying to do a little bit of everything? So it's not unusual that you're here for a second opinion and you didn't get a great result. So a lot of this technology, it's onerous, but you have to invest in your own practice. The government is requiring us to do electronic medical record keeping. So if you get in the hospital here, or Lehigh Valley, Philadelphia, New York, your little records will go with you. But you know, that's sort of a little caveat to look for the rotary phone, and it's kind of a sign. Yes, Deb.
I just want to share with everyone what a miracle worker Dr. Meade is. My mom just turned 80. By the way, he and I go back to high school. So I knew him when he was going to Burger King. My mom just turned 80, and she was incapacitated by her right knee problem. And about a month ago, we went to Dr. Meade, and he removed fluid from my mom's knee and I believe gave a cortisone shot. My mother is a different person. She can walk, she can go up steps. I can't believe the level of not being able to walk compared to being able to walk. She still has some residual pain. My question is, Like, how often do you give the cortisone shot? I know it's probably individual, but like, how long does the shot usually last, and how frequently? Thanks.
Great question, Deb. It's a great thing. I'll preface the answer by saying we try to keep everyone out of the operating room. Injections, fish oil, weight loss, activity are probably 4 things that we do to keep everybody out of the operating room. Once a month, somebody scheduled for knee replacement calls and cancels on the fish oil. The injections, again, I can talk for another hour on the hyaluronic acid that I think is overdone. The efficacy is not what it's purported to be. Cortisone injections virtually help everybody. 90% get better. The only question is, how long does it last? The range is a week to 4 years. I've had people come back and say, I want that shot. I go, when did I give it to you before? They said 4 years ago. Can I have the 4-year shot? If I drew a bell-shaped curve, I'd say about 3 months is probably the average. There is no absolute. Can you give injections every week? Sure you can. Ask the NFL guys that are out there, but they have total knees by the time they graduate. So good medicine in general, you kind of don't want to do it more than every 3 months, but it is not absolute. There are patients that can't have surgery in nursing homes. I'll inject them every 2 months to give them a quality of life, just like Debbie said. So that's a great ending question, folks. Thanks for coming. I hope we answered a lot of your questions. I'm proud of my high-performance team and to bring it up here to the Wyoming Valley. So you're not going to want to miss our next show. Thanks, and I hope you had a good time.